What I want to do is talk to you guys about neuroinflammation. If you're doing brain rehabilitation, whether you're looking at a person with a traumatic brain injury or neurodegenerative disease, it's very likely that the patient may have some degree of neuroinflammation. And neuroinflammation is going to do several things that really hinder your clinical outcomes with any kind of rehabilitation program. So neuroinflammation uncouples mitochondria. So it's really easy for patients that have neuroinflammation to fatigue. So if you're doing any kind of therapy with like eye movements or any kind of sensory technique or whatever therapies you're doing to impact the injured areas of the brain or areas of the brain that are neurodegenerating, if you see a patient quickly fatigue, you can only do a couple sets and they get tired, or you send them home with exercises and they get worse because their brain's fatiguing. That's one of the things that takes place with neuroinflammation. So be very aware of that some of these patients that have traumatic brain injuries or have neurodegenerative diseases, the pathophysiology of their condition is that they have activation of their inflammatory pathways in the brain. So it's very easy to fatigue them, and then you should consider taking strategies to improve their neuroinflammation before you start some rehabilitation. The other key thing is that when you're looking at doing therapeutic exercises to support the brain, you're really trying to develop synaptic branches. You're trying to develop plasticity. And plasticity and synaptic branches really require release of things like BDNF, brain-derived neurotropic factor, to allow those neurons to really branch out. And under states of inflammation, you really have a impairment of these neuron branching responses. So one of the most important things to really pick up on when you're suspecting brain inflammation is the patient comes in, they obviously have neurological deficits in where areas you've identified. But a lot of times you'll see symptoms of brain fog. They can't think, they can't focus, they can't concentrate, or those are many times specific only to the frontal lobe. Or you just may have injury, like if someone who's got a cerebellar injury, they just may have fatigue as soon as they try to activate the cerebellum or do anything that involves those injured pathways. So you want to look at nutritional strategies to really dampen neuroinflammation. And Apex has a few things that are really important for neuroinflammation. Let me go over these first, and I'll show you some research and mechanisms behind these things. Glutathione can be one of the most important nutraceuticals to really support neuroinflammatory responses. And I really believe Apex makes the best glutathione product. It's called trisomal glutathione. And the key thing with this and makes it so effective is that it's liposomal. And not only is it liposomal, but it's the S-acetylglutathione version of it. And it also has precursors to help glutathione. And the combination of those things really help deliver glutathione really well. For many people that have tried the trisomal glutathione, as soon as you take it, you immediately notice a significant benefit in just how you feel and your well-being because it's so quickly absorbed. So this is really critical with patients that have neuroinflammation, increasing the glutathione levels and using a liposomal and acetylglutathione form in addition with N-acetylcysteine really is a great way to really raise glutathione levels and deal with inflammatory responses. And then recycling glutathione, once it's made from reduced to oxidized form, becomes very, very powerful. So in my practice, when I see neuroinflammation, I'll use the trisomal glutathione in combination with glutathione recycler to help improve the regeneration of reduced glutathione from oxidized glutathione. And then I'll use high amounts of turmeric. And when you look at turmeric, you really want to have highly active curcuminoids. And when you have an emulsified micronized curcuminoids, you really deliver some very powerful anti-inflammatory flavonoids. And the key thing with curcuminoids is that curcuminoids can cross the blood-brain barrier, so they can actually get into the brain. Not all flavonoids can do that. So I'll use Tumero Active in my practice with neuroinflammation patients. And for some patients that travel or can't take a liquid form, because this is liquid form, I'll have them take a capsule version of the same product called Tumero SC, if that applies. And then I also will use Resveratrol Active or Resveratrol. Resveratrol is also another very powerful compound that helps with neuroinflammation, helps heal the blood-brain barrier, helps with mitochondrial uncoupling, turns on mitochondrial biogenesis pathways, and a trans-resveratrol form is really the best type you can use, and an emulsified trans-resveratrol form of resveratrol is very effective. And for patients that are traveling at times or at work and can't take a liquid form with them all the time, I'll use the capsule. And some patients use the liquid ones in the forming, and some use the capsule. And then lastly, short-chain fatty acids. Short-chain fatty acids have been shown to really impact neuroinflammation from the gut-brain mechanism. And short-chain fatty acids dampen microglial activity, and they have some very powerful effects on regulatory T cells in the gut and even in the brain. And I'll show you some of those studies in a second here, but those are the main things that you really want to consider when you have neuroinflammation. So the combination of liposomal glutathione with the trisomal glutathione, with glutathione recycler, with Tamaraactive as Veroactive, some Enterovite is giving you a grand slam home run with nutraceuticals that have been shown to dampen brain inflammation. Really important for traumatic brain injuries, really important for people that have neurodegenerative diseases, and especially if their inflammatory pathways are getting in the way of rehabilitation recovery. Now, when you look at when you look at practitioners that are really focused on neurorehab, and they're very skilled in looking at the neurological pathway that's involved, looking at the neurons that are involved, but they don't really pay attention to the glial cells. And this is where neuroinflammatory models come in. So glia, as you guys know, is a Latin word for glue, and they initially thought that these glial cells just glued neurons together. But we know that these glial cells do much, much more, and these glial cells are involved with modulating synaptic activity. They control glutamate to GABA responses to modulate neurons. They help get rid of debris in the brain, like amyloid plaques, alpha-synuclein, and beta amyloid. They also are really important with maintaining the blood-brain barrier. Now, one of the most important glia are microglial cells. And if you take a look at this slide here, you can see M is microglia, A are astrocytes, O are oligodendrocytes. And these are different glia. And you can see that microglia actually move and they scavenge around the brain and they get rid of debris. This is a normal, healthy response that we should have in the brain. Astroglial cells are involved with the blood-brain barrier. Oligodendrocytes are involved with the myelination of the brain. But these glial cells are absolutely critical for normal brain function and to really help neurons function more efficiently. When people have neuroinflammation, it's these microglial cells, these astroglial cells that get activated and create surrounding inflammation which get in the way. Here's another really cool video of a microglial cell just roaming through the brain. You can actually see it move through. So these glial cells are active and they're moving all throughout your brain, getting rid of debris and quenching inflammation. Now, you should know that if you're dealing with someone who's got neuroinflammation, whether it's from trauma or neurodegeneration, there's pathways throughout the body that turn on brain inflammation. There's a saying in functional medicine, functional neurology, where, inflammation in the gut, inflammation in the body means inflammation in the brain. And this is because inflammatory cytokines cross the blood-brain barrier and they turn on and activate these glial cells, which then create some degree of neuroinflammation. Now, there's different pathways where inflammatory mechanisms turn on brain inflammation. So inflammatory cytokines generated, for example, in the gut, or generated by adipocytes in body fat, or generated by hepatocytes in the liver. They can go through passive diffusion, cross the blood-brain barrier, and turn on these glial cells towards an inflammatory state. Also, pathways from the gut or from the liver can directly go through vagal afferents up the vagal pathways, these inflammatory messengers, and then turn on glial cells in the brain. Or you can actually have some active transport pathways where inflammatory mediators cross into and turn on blood-brain barrier responses, or even at the vascular epithelium where astrocytes get activated and turn on neuroinflammatory responses. So once someone has a traumatic brain injury or someone has neurodegeneration, the inflammation they have from other conditions throughout their body, whether it's hepatitis, whether it's inflammatory gut disease, whether it's rheumatoid arthritis, whatever the situation mechanism may be, whether it's asthma, these inflammatory triggers also create inflammation in the brain, and they turn on these microglial cells. Now, microglial cells can be in what's called a steady state or an activated state. So let me show you the key difference here. Here's microglia, and you can see these microglia are not activated yet. They're just, you can see they have these legs, and these legs will allow them to move around and roam around like those videos I showed you. And they're just basically going around the brain, getting rid of debris and build up protein aggregates. And at some point, these glial cells can become activated, or they call primed. And like, for example, this can take place after a traumatic brain injury or a significant inflammatory response in the brain, even an infection or something that infiltrates the blood-brain barrier. And these, microglial states go from a steady state to an activated state, and they can either express into what's called an M1 response or an M2 response. And right away, what you'll see is their morphology changes. They lose their legs. They are now enlarged. And at this point, they stop moving. They stay in the area of the injury or where they got activated. And the M1 type is involved with causing neuroinflammation, and they create an inflammatory response. And then the M2 type is involved with an anti-inflammatory response. One of the easiest models for this to look at is a traumatic brain injury. So let's say someone gets an injury to the frontal lobe, and the injury impacts these glial cells. Their M1 and M2 levels initially go up during the acute injury. The M1 pathway for inflammation is there to get rid of debris and to get rid of the injured neurons that are there, so you can clear out those pathways. And then the M2 pathway comes in to heal the inflammatory reaction. The key thing, though, is after these microglial cells get activated and get what's so-called primed, where they stay in this position, they only switch into an M1 state. So after the initial injury, M1 and M2 go up, but then after the injury, they stay in an M1 stage. And the key thing with these microglial cells that get primed is their morphology changes as they get activated, and they stay the same, but now they're prone to inflammation. Any inflammatory responses throughout the body then turns these on. This is why, for example, someone can have a frontal lobe injury and then have asthma, get exposed to air pollutants, and then have their brain fog and their brain function go down. This is why someone can have a frontal lobe injury, for example. It could be cerebellar parietal, doesn't really matter. They can have a brain injury, and then they can get exposed to dietary proteins that cause gut inflammation, and now their brain injury is activated and they feel much, much worse. So the key thing is that once people get traumatic brain injuries, those areas of the brain then develop prime glial cells, and then those prime glial cells can get activated by any inflammatory cascade. That's why it's so critical to dampen these inflammatory responses. When you look at the models of traumatic brain injury, they look at the first hit, the glial cells get primed, they get changed into a inflamed state, and then anything that activates it secondarily can cause significant symptoms and so forth. And here's another model of that. Here you see microglials. They're in a regulated, steady state. They're resting. They're allowing for homeostasis, getting rid of debris. Something turns them to be primed. Maybe it's a metabolic inflammatory response. Maybe it's a brain injury. But then these glial cells lose their legs. They become primed, and their shape structures changed. And then any single inflammatory response that takes place, whether it's from an infection or from systemic inflammatory response, or from, let's say, just even obesity, or whatever the mechanism may be, activate these neurons and then disrupt neuronal function. So that's the key thing with neuroinflammation and glial priming. So when microglial cells transition into a primed state, they only go from left to right. They don't reverse back. So once they get formed, they're there. Just like a hard-boiled egg. Once a hard-boiled egg gets formed, you can't reverse it. So that's the key thing. Here's some videos of prime glial cells. And what happened in these specimens here is they took glial cells and they activated them with LPS. LPS is something that shows up when people have endotoxemia, and it's caused by gram-negative bacteria being released through the gut barriers, through intestinal permeability, and then it turns on these glial cells. So breached blood-brain barriers, leaky gut, with dysbiosis has a chance to promote neuroinflammation. So here you can see these glial cells, they're moving around. You can see the size of them. You can see that they still have their legs, moving them around, and everything's fine. They're doing what they need to do. And then the next slide, they get exposed to lipopolysaccharides, gram-negative bacteria, so-called leaky gut, leaky brain pattern. And then what you'll start to see is these microglia Some of them, as they get activated, like this one here, they lose their legs, they enlarge, and now they're in an active state. So that's microglial priming. And this is one of the things that happens with many people, especially with inflammatory reactions against their brain. And then these glial cells stay primed for the rest of their life, and they are always sensitive to inflammatory reactions. This is why some people, when they get exposed to a dietary food, whether it's milk or gluten or what other food they react to, all of a sudden have their brain shut down, and other people don't. Some of the reasons why is that they've already had some primed glial cells in those regions of their brain. Here's a study of glial cells before traumatic brain injury. This was an animal study. And you can see glial cells functioning, moving around, everything's fine. And then after a traumatic brain injury, they're enlarged, they stop moving. These are not primed glial cells. So if these primed glial cells were in the cerebellum, I can have an activated inflammatory response anywhere in my body, and all of a sudden my cerebellar findings would come out. If I had primed glial cells in my parietal lobe or frontal lobe or basal ganglia, it doesn't really matter. Those cells can become activated, and then as neurons get activated, as microglia get activated, they create a neuroinflammatory cascade, and these neuroinflammatory cascades have the potential to decrease neuron conduction speed and a couple neuron mitochondria, so neurons don't function anymore, and it's like as if the patient gets re-injured again. They're not getting re-injured again, they're just losing their oxidative ATP potential, oxidative phosphorylation ATP synthesis potential, and they're also slowing down the nerve conduction pathways. So we know that priming takes place after brain injury, and when you look at the scale and severity of neuroinflammation, the most subtle symptoms is just brain fog, hazy thoughts, recall. These are associated with the frontal lobe. Really depends on the brain, but a key thing is reduced brain endurance. So again, anytime you see a patient you're trying to do neurological rehab with, and they just fatigue and crash with any kind of stimulus, you may have some primed glial cells, neuroinflammatory responses there. Chemicals, pollutants, those things can also trigger these responses. And if it gets to be moderate neuroinflammation, they get severe depression, they get sleepiness, the brain just shuts down, they can't function afterwards. This is the classic example of a patient coming in with a brain injury or a neuroinflamed brain. They get a neurological exam, and maybe the practitioner doesn't even do any kind of therapy or treatment. Patient calls back and says, I can't function, and they're in bed for 3 days. That's the classical pattern of neuroinflammation. And then with more severe cases, they get delirium or they get dementia. Like with lots of elderly patients, one of the most common causes for them to get delirium, disorientation, is they get a bladder infection. And they already have primed glial cells from the neurodegenerative process, and then they get a bladder infection, and all of a sudden they have delirium and confusion and disorientation. And it looks like they had a stroke, but really it was just these primed glial cells being triggered from their bladder infection. Now, when you look at neuroinflammation, there's different degrees. There's transient neuroinflammation that comes and goes. So if someone has some degree of neuroinflammation, it comes and goes with environmental exposures, dietary exposures. There's people that have chronic neuroinflammation. They get a head injury, they're never the same. They can always have some degree of inflammation. Then they get these primed glial cells, which can get reactivated at any time. And then these eventually developed into neurological autoimmunity, which is much more severe. So we all have some degree of inflammation in our brain. Some have more where it's chronic. The worst scenario is if there's glial priming. These primed glial cells just stay there forever until they go through autophagy and get eliminated, which can take some time. Now, here's an interesting paper. It was called Priming the Inflammatory Pump of the CNS After Traumatic Brain Injury. This was published in Cell Press and Trends in Neuroscience. And here's what they found, some key concepts about these glial cells in traumatic brain injury. Microglia are rapidly activated following traumatic brain injury and produce cytokines and chemokines in addition to exhibiting morphological alterations such as hypertrophy and deramification processes. That's them losing their legs. Experimental and clinical evidence indicate that microglia do not return to homeostasis after injury, but instead develop a primed and potentially hyperreactive phenotype from that point on. Prime microglia are characterized by exaggerated responses to secondary insults, such as repeated traumatic brain injury, immune challenge, or stress. This results in amplified and prolonged neuroinflammation that negatively influences cognitive and behavioral processes. And then these patients with prime glial cells, TBI patients, are at increased risk for development of depression and neuropathologies, tau, after injury. And microglial-mediated inflammatory processes may represent a useful clinical target in treatment of neurological and psychiatric disorders. So, clinical pearl. Traumatic brain injuries can lead to symptoms 5 to 10 years after the initial injury. So there's some people who have like chronic depression and can't focus, the brain doesn't work. They didn't notice the symptoms initially, they get a traumatic brain injury, glial cells get primed. Over a period of time, these glial cells getting primed and creating inflammation uncouple surrounding neurons start to degenerate, and then symptoms start to show up. Anytime you see a case history with symptoms of neuroinflammation, like they can't think, they can't focus, the brain symptoms get pronounced or activated from inflammatory triggers, you got to think of past history of a TBI. And TBI is the most concerning of the patient lost consciousness after the injury. You should know that if a person has a significant injury where they lose consciousness, you have some degree of glial cell priming caused by that injury. Now, remember, the force of the impact is not the only variable that determines the severity of the traumatic brain injury and potential for microglial priming. All the physiological variables that can impact the shift of microglia to greater M1 activity before the impact can have a profound impact on the severity of the TBI. So what this means is that, if you have someone, for example, that already has some degree of neuroinflammation, let's say you take a diabetic who's also a smoker, and they get a traumatic brain injury, well, the fact that they have diabetes and hyperglycemia and hyperinsulinemia and glycosylated end products churn on prime glial cells anyway. And then if they're a smoker, they have oxidative stress and some degree of hypoxia to the brain. If they get a traumatic brain injury at the same degree of a force that someone else that doesn't have those underlying mechanisms, their injury wouldn't be as significant. So the more inflammation, the more inflamed neuron, the more inflamed the brain is with activated resting glial cells, the more significant a traumatic brain injury is. If you take a group of 100 people in a room, every person in that room has different degrees of neuroinflammation. And also, there's different degrees of glial priming with every single person in the room. Some have significant priming that they may not even know about, and some may not have much. Now, what are the clinical strategies for neuroinflammation? Well, you really want to change this M1 expression into an M2 expression, and several things have been shown to do that. So, from a dietary perspective, ketogenic diets, intermittent fasting have been shown to shift M1 into M2. And then nutritionally, short-chain fatty acids have been shown, like things like butyrate, acetate, propionate, have been shown to dampen neuroinflammation. So in this paper that was published in Frontiers, titled How the Interplay Between the Commensal Microbiota, Gut Barrier Integrity, and Mucosal Immunity Regulates Brain Autoimmunity, they really show that when there's inflammation in the brain, they can see like an MS with white matter lesions, that if they take a high fiber diet and take things like short-chain fatty acids, that immediately changes the expression of inflammatory responses in the gut, and that has an anti-inflammatory effect on the brain. We also know that short-chain fatty acids, which you can increase by eating fiber or by taking acetate, butyrate, and propionate as a supplement, turn on T cells, regulatory T cells that dampen inflammation, not just in the gut, but also in the brain as well. So numerous studies have shown that the short-chain fatty acids have an anti-inflammatory effect, and they also help with immune response and activity and help protect the gut with different pathways. But look at this paper here, dietary fatty acids susceptibility to MS. Conclusion, dietary short-chain fatty acids constitute interesting candidates as safe and potent add-on therapy in the immunomodulatory treatment armamentarium for relapsing remitting MS. And look at the title of this paper, Short but Smart, Short-Chain Fatty Acids Train T cells in the gut to fight autoimmunity in the brain. So we know that dietary short-chain fatty acids can dampen the inflammatory pathways in the brain. This is a study where they looked at taking short-chain fatty acids, dampening inflammatory reactions in the uvea, the eye. You can see here normal. You can see here the inflammatory uveitis, and they gave these group of subjects butyrate. You can see how their gut was able to heal from that pretty quickly. So short-chain fatty acids are very important. Things like glutathione are very important for dampening the inflammatory response. Things like resveratrol are very effective, and things like turmeric are very effective for dampening microglial neuroinflammation and turning these primed glial cells into M1 responses. So, and once again, the key things you should think about when you're looking at a patient that has neuroinflammation from a nutraceutical perspective would be taking short-chain fatty acids, things like enterovite, taking very highly absorbable glutathione in an acetylglutathione liposomal form, like trisomal glutathione, taking things that help recycle glutathione from reduced to oxidized state, like glutathione recycler, high amounts of curcuminoids, and high amounts of transresveratrol to support physiological pathways to improve anti-inflammatory effects. So these nutraceuticals are basically used to support healthy anti-inflammatory physiology, and they should definitely be in your tool bag if you're dealing with people that have neurodegenerative diseases or any type of traumatic brain injury. So I hope those tips help, and thank you for your attention.